A production fee for your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.
Atlantic Health reported in a recent online article that women need a gynecologist every stage of life, beginning at the age of their first menstrual cycle and later as a guide to birth control options on fertility, healthy pregnancy, and postpartum wellness. Then as women mature, seeking other health and wellness issues. The report concludes that every stage of life, a trusted gynecologist who will listen and support your needs is an essential component of overall health care. On this edition of your Hometown Health Connection, we will meet a leading Western New York gynecologist with answers to some of the questions you might have on your Hometown Health Connection. I'm Erica Brecher. Welcome to the program. Born and raised in Buffalo, Dr. August Bruno Jr. is board certified in obstetrics and gynecology. He completed his medical school and residency training at UB and treats all aspects of women's reproductive health. He cares for both normal and high-risk obstetrical patients and manages all aspects of gynecologic care. Dr. Bruno is trained in minimally invasive surgery, including robotic and laparoscopic treatment of complex gynecologic conditions such as uterine fibroids, advanced stage endometriosis, and pelvic organ prolapse. He has extensive training in managing urogynecology dysfunction and in performing surgical treatment of severe pelvic organ prolapse, surgery for vaginal pelvic relaxation, and pelvic reconstructive surgery. In addition to some general questions, we have two important topics we are going to explore more extensively. And in our first segment, we're talking about abnormal bleeding. So welcome, Dr. Bruno, to the program.
Thank you for having me.
Sure.
I appreciate the opportunity.
It's a great opportunity. We got a lot to learn here. So we'll get right into the first question, and that is, what is abnormal uterine bleeding?
So that is a term we use that refers to menstrual bleeding disorders and uterine bleeding with regard to abnormalities in schedule, amount, and duration. As clinicians, we evaluate menstrual patterns according to 4 profiles: frequency of bleeding, regularity of bleeding, duration, and volume. Frequency of bleeding basically relates to onset of one cycle to the onset of the subsequent cycle. How many days are the cycles separated by? Regularity is an evaluation of how repetitive and repeatable are a woman's cycles. A little variability is okay, but wide fluctuations, wide variation in timing of bleeding is abnormal or may be abnormal. And that can secondarily influence frequency based on bleeding patterns. Duration is fairly straightforward. It's bleeding from start to stop. So the total number of days, and that's irrespective of whether or not the bleeding is normal, light, heavy, spotty, intermittent. It's just the total length of bleeding. And then there's volume. That's a little bit more of a subjective category. We obviously can't ask women to measure menstrual blood loss. We do know that most women bleed a fairly equal amount from cycle to cycle. It's usually 80 cc's or less, or about 3 ounces. But what we're looking at is quality of life issues. How do their bleeding patterns affect quality of life negatively with regard to mental, physical, emotional, and social health?
So really, how disruptive are these abnormalities?
Correct. So they may technically have normal bleeding patterns if you look at how their bleeding profiles fall into the norms. But if it's very disruptive, then it needs to be addressed, and we're trying to assist patients with dealing with the issue.
Great. Thank you, Dr. Bruno. Our next question is, how significant is this problem for reproductive aged people?
Unfortunately for women, it's very common. So if you actually look at the number of problem-oriented visits for reproductive age women to their women's health providers, about 1/3 of all visits are for bleeding issues and abnormal bleeding. And that number balloons to about 75% of patients who are perimenopausal, those that are transitioning to the termination of their reproductive life. There's a lot of variability in their hormones at that stage. There's menstrual irregularity to begin with, and that influences their bleeding patterns, especially if they have associated pathology. It's not unusual that they have this high incidence of bleeding abnormalities, and the reasons are Three, basically. First of all, most of the common causes for abnormal uterine bleeding are highly prevalent in the general population. About 25% of women will have these conditions, whether or not they manifest. And secondly, a woman's reproductive life cycle is about 4 decades, or about 500 menstrual cycles. So that provides a huge window of opportunity for these issues to manifest. And lastly, the cycle itself is highly complex, highly intricate, and it's well orchestrated, and it involves coordinated function between 3 systems: the gland in the brain, the ovaries, and the uterus. And anything that disrupts the circuit, or any abnormalities that develop at any of these stations, can lead to abnormal bleeding.
A lot to consider there,
Yeah.
especially as it pertains to age and where somebody is
Correct.
in their life and reproductive health.
And how we will treat them based on where they are as well.
Thank you. Well, what signs would a woman look for indicating that a potential problem exists with regard to their menstrual cycle?
Well, they're going to want to look at their cycles based on the profiles that we outlined: frequency, regularity, duration, and volume. Most women are, whether consciously or not, actually tracking their cycles on a regular basis. It's not uncommon that patients come into my office, whether it's for a well visit or a problem visit, and they'll have statements such as, I started to notice I was bleeding for more days, or the interval I had between was getting shorter, I was needing to use more sanitary products, or they weren't lasting as long. And then they start tracking. So they're going to want to look for changes in their menstrual patterns, or anything that would indicate, an alteration of their normal bleeding sequences. In this technology age, everybody knows what apps are. A great resource for patients and clinicians is just a menstrual app. They can download these to their smartphones, tablets, and these are very helpful. They actually help women to catalog and keep a diary of their bleeding patterns. And most of the good apps actually will provide them alerts as to whether or not the bleeding is potentially problematic and whether or not they should seek evaluation. From a clinician's perspective, it's great for me because patients come in with their phone or their tablet, they open it up, and I can see their bleeding patterns in 5 seconds, decide this is okay or this isn't. In the olden days, someone would come in with an index card with their bleeding patterns and recite them to me, and I'm trying to figure out how frequent, how long, and it's a little bit difficult to calculate. So it's very useful for both of us. And it's also, with the electronic health record, patients can download their bleeding patterns, send me a quick note, and I can review it and say this is okay, watch for X, Y, or Z, or come in for an evaluation.
Well, it's so great to know that these tools exist. Even the Fitbit has it. Maybe it's
Right.
not a menstrual specific app, but just my Fitbit has something like that.
Correct.
I know.
Yeah.
Well, what are the most common causes of abnormal uterine bleeding?
The list is long, but we'll focus on the common. So we break them down into 2 categories. We have what are called non-structural causes and structural. The structural are basically related to abnormalities of the uterus. The non-structural causes most commonly are related to hormonal imbalance. So anything that disrupts the normal ovulatory cycle, they affect ovarian function in a negative way. There's some endocrine disorders such as hypothyroidism that can alter ovarian hormone production. There's some syndromes that we have in gynecology, polycystic ovarian syndrome, where there's an imbalance of hormones, and that manifests as irregular bleeding. The cycle really needs to have a balance between the 2 predominant hormones, estrogen and progesterone, and anything that tips the scales one way or the other leads to abnormal bleeding. So we can treat that by regulating their cycles with a variable options: low-dose birth control pills, progestational injections, or IUD implants, things of that nature to level out the playing field when it comes to the hormonal imbalance. In terms of the structural abnormalities, there's basically 4. We have an acronym for it. It's called POM, for polyps, adenomyosis, leiomyoma, which is fibroids, we'll talk about later, and malignancy. Endometrial polyps are fairly common and easy to manage and diagnose. These are abnormal growths in the lining of the uterus, like polyps other organs of the body. We can usually pick these up on a very simple office procedure, an endometrial biopsy. They're almost always benign. There are a few that have some premalignant or cancerous potential. We would want to treat them because we need to rectify the bleeding problem. And that can be done for a simple procedure called a hysteroscopy. It's an outpatient surgery where we can insert a scope into the uterus, identify the polyp, resect and remove it, and take care of the bleeding problem. Some women that have significantly abnormal bleeding, we can add on doing a secondary procedure at the same time. It's called an endometrial ablation, where we insert an instrument into the uterine cavity that dissipates thermal energy that inactivates the lining of the uterus and can shorten and lighten and almost eliminate their menstrual cycles. The second condition is hard to treat, adenomyosis. First of all, it's difficult to diagnose and there is no diagnostic test for it. We can have some idea that it's present based on some imaging studies, that being ultrasound or MRI, but it is actually a tissue diagnosis. So we find this after a patient has ultimately ended up with having a hysterectomy. These patients have very long, heavy periods, tremendous menstrual cramping, and they usually fail conservative therapies. We've tried medications, we've tried endometrial ablation, a progestational IUD. They finally are at their wit's end. They move on to definitive surgery, and the pathology reveals adenomyosis. And that's curative to do that procedure. Leiomyoma, fibroids we'll talk about later, and then the last structural abnormality of the uterus of concern is malignancy. It's not very common in the reproductive age women. It tends to be a postmenopausal issue, but it can be present, especially patients who have risk factors. The obese patient or those patients with chronic anovulation, that imbalance of hormone leads to overstimulation of lining of the uterus from estrogen, and this can cause abnormal growth and proliferation and thus manifest as bleeding abnormalities. And it's actually a condition called hyperplasia, which if untreated can progress to a cancer. So we rarely find it in reproductive age women, but physicians and clinicians don't want to discount it and not know that it's a potential problem, especially in at-risk patients.
Kind of take into consideration everything for the sake of the patient. So we are almost out of time, but just to summarize, treatment options. Sounds like they can range from conservative options like birth control all the way up to a hysterectomy. Is that correct?
Correct. So options are going to be based on where a patient is in her reproductive life. You know, what are her future goals? Is she still interested in childbearing? How close is she to menopause when her bleeding is going to stop naturally and we don't have to intervene? I just need, you know, in that patient who's on the bridge to the other side, I just need to help her to get over there. And she's going to stop on her own and no intervention is warranted. So a lot of options.
A lot to consider there. Thank you, Dr. Bruno. We will continue our conversation with Dr. Bruno right after we share some important contact information. If you would like to make an appointment to see Dr. Bruno, you can give his office a call at 716-656-4077. That's 716-656-4077. He has 3 offices he practices out of at 5959 Big Tree Road, Suite 102A in Orchard Park, 520 Delaware Avenue in Buffalo, and 1000 Youngs Road, Suite 106 in Williamsville. You can go online for more information also at gppconline.com.
Buffalo Healthy Living Magazine is a free, full-color magazine distributed throughout Western New York. Now, more than ever, as we all want our families and friends to be safe and well, Buffalo Healthy Living Magazine is devoted to health, fitness, and nutrition for people of all ages. It's a great read and also has great recipes. Pick up Buffalo Healthy Living Magazine all over our hometown or go online anytime at buffalohealthyliving.com.
Welcome back to your Hometown Health Connection. I'm Erica Brecher. We're continuing our conversation with gynecologist Dr. August Bruno Jr. with General Physician PC, pivoting now for this segment to cover the topic of uterine fibroids. You mentioned that uterine fibroids are a very common cause of Bleeding and menstrual abnormalities in women. What are uterine fibroids?
Fibroids are benign tumors of the uterus or womb. They are the most common tumor of reproductive age women. They affect approximately about 50% of women of reproductive age. By the time a woman gets close to menopause, the incidence can be as high as 80%. So the uterus itself is a very unique structure. It's basically a muscle. It's a smooth muscle that is filled with cells called fibroblasts. These cells undergo abnormal proliferation and growth, and it manifests as solitary tumors. So we've termed them fibroids. And they can also develop, if they are not solitary tumors, just overall increased volume in the size of the uterus. So the wall of the uterus is thicker, the actual size of the uterus that fills the pelvic cavity is enlarged, and they contribute significantly to abnormal bleeding problems. They are the #1 cause of hysterectomy, or reason that women undergo hysterectomy in the United States, and the #1 cause of abnormal uterine bleeding.
Wow, so it's a big problem sometimes.
Yes,
Can be.
significant.
Wow, okay. What causes fibroids to develop?
We're not sure, but it is hormonally mediated. Over the repetitive nature of a woman's menstrual cycle, with the stimulation of hormones released by the ovaries, the pulsatile nature of that on a cyclical basis will generate abnormal growth and proliferation, and over time these cells undergo abnormal transformation and it manifests as these tumorous growths. We do know that there are certain risk factors. Anything that causes hormonal imbalance can play a role, obviously, and then there are some other general risk factors. We see them more in families, first-degree relatives, mothers, sisters, daughters. They're more prevalent in the African American population. Obesity plays a role. These women have higher circulating levels of estrogen, so they tend to have a greater problem with fibroids and a higher incidence of fibroids and fibroid-related disease, things of that nature.
So there's at least some correlation with certain demographics.
Correct, yes.
How might a woman know that they have a menstrual disorder related to fibroids? What are some symptoms they might have?
Well, in addition to the abnormal bleeding, these tumors can get very large. The uterus's unique capability to expand and stretch is one of the culprits, because it allows these tumors to get to very large size. So patients will develop bulk symptoms, as we refer to them: pelvic pressure, pelvic heaviness. It can lead to urinary issues. If there's tumors on the front wall near the bladder, they have urinary frequency, bladder pressure, urinary incontinence, rectal pain, constipation, painful intercourse, and very heavy and prolonged and painful periods. Patients who have very large tumors, they can actually notice that their lower abdomen swells. Some women will feel that they can't fit in their clothes the way they used to, almost as if they're pregnant, because these can get to tremendous size.
So there's these physical presentations, but then, as you described, some certainly quality of life issues that
Correct.
may lead them to thinking
Yes.
something might be wrong here.
Yes.
How are fibroids diagnosed?
They're fairly easy to pick up on clinical pelvic exam. Once you suspect that, most patients are referred for imaging studies. The most common modality is pelvic sonogram or ultrasound. There is also pelvic MRI. These are very useful. They're not necessary to get a confirmation ultrasound or MRI, but it's going to be a necessary piece of information, especially for patients who are seeking treatment. The ultrasound or MRI can actually provide a map of where the tumors are, their location, their size, their volume, which is going to influence treatment options.
So that's, you look using that technology, and that helps you find if and where these fibroids may be.
And confirm, yes.
What are the potential problems or health risks related to fibroids?
Well, if the bleeding is significant enough, and it can be profuse in some of these patients, it can lead to chronic blood loss anemia. For patients who are chronically anemic and then have acute bleeding issues, they can get severely anemic and require transfusions. It can cause what's referred to as obstructive uropathy. If they have a large tumor that can obstruct or block the urinary tract, which can lead to kidney dysfunction. Some of these tumors get extremely large and can actually become parasites. They sort of outgrow their uterine blood supply, so they attach to other organs like the bowel, the intestines, and they sort of steal blood supply from them. So abdominal pain, bowel blockage. So there's a whole host of things.
Are they always benign? You mentioned at the beginning that these are benign growths.
They are. They're always benign. The only caveat to that is the sister cancerous tumor is called a uterine sarcoma. So those present with similar bleeding problems. It's typically a postmenopausal patient, however, and those tumors grow very rapidly. So we have to keep that in the back of our mind, but sarcomas are rare to begin with. These tumors are always benign. They do not have premalignant potential. They do not degenerate. They don't turn cancerous later in life.
Good to know. What treatment options are available to women who are having fibroid-related bleeding disorders, and how successful are these treatments if that's something you can measure?
First of all, treatment is again going to depend on where a woman is in her reproductive life. If they are still interested in childbearing, many of the options that are conservative but minimally invasive are contraindicated, so they would not have that option available to them because they can raise the risk of pregnancy-related complications. It also depends on where a woman is in her menstrual life cycle. If they're closer to menopause, maybe we can temporize. Maybe we can use a more conservative measure. First-line therapies will typically be medications that control the hormonal environment that influences the bleeding patterns and their growth. So we're trying to stunt that growth. We use low-dose birth control pills, progestational injections or implants, oral progestational medications. There is a class of medication called GnRH analogs. They basically shut down ovarian hormone production and put a woman into a menopausal state. In doing so, they cut off bleeding. They can cause the tumors to maybe shrink a little bit in size. The problem is that they can only be used for a short time frame. So these are more bridging options. Somebody who is ultimately going to have a surgical procedure, but it's not the right time socially or job-related issues. They just need to defer. So that's a relatively new medication that's available. Works well. Then we can move into minimally invasive procedures. Where the tumors are located is going to play a big role, and how big they are and how numerous they are. So if you have very large tumors, it would contraindicate some of the therapies. If they are not vascular enough, some of the treatment options won't work. And if they're too numerous, some of these options are not available. Beyond medical therapies, we have what are called minimally invasive, non-surgical options. The three that are available now are uterine artery embolization, radiofrequency ablation, and ultrasound ablation. Uterine artery embolization is a procedure done by an interventional radiologist who places a catheter into the uterine vessels and basically injects product to occlude the vessels that shuts off blood supply to the uterus. This improves their bleeding patterns about 80% of the time, but it's not good at treating the bulk symptoms, the pressure, the pain, so it's mostly for bleeding. A small percentage of women will still fail that therapy and go on to have a hysterectomy. It's about 1/4 of them. And even smaller population will actually lose their ovarian function, so you have to inform a patient, this is a great option for you, but you're only 40 years old. If you lose your ovarian function, you've lost 10 years of your reproductive life and hormone production. Radiofrequency ablation is a relatively new technique. It's been around for the past decade. It's done either hysteroscopically, where an instrument's inserted into the uterine cavity, or through a laparoscope, a minor surgical procedure with small incisions made in the abdomen. And electrodes or probes are basically placed into the tumors, and they emit electrical and thermal energy, which causes the tumors to shrink and dissolve, if you will. Again, it's more for the bleeding problems and not related to the bulk issues. The final newer option is ultrasound ablation, where targeted ultrasound waves of high energy are shot, if you will, at the tumors and shrink them and can make them become inactive and can improve bleeding patterns. So all of these three have about an 80% success rate, but they're really reserved for patients who are having the bleeding issues. All of the other bulk issues, pain, pelvic pressure, is treated with alternative options.
Well, it's nice that, once again, we're looking at a range of therapies that could be conservative to something that's temporary, as you described, all the way up to those things if women have tried everything else and maybe need that. So lots of options out there.
Right. And even for the surgical therapies, there's been a shift to more conservative approaches with the advent of laparoscopy and the proliferation of microinvasive, minimally invasive procedures, robotics. We can now handle many of these cases through less invasive procedures and have patients have a quicker recovery than the old-fashioned abdominal incision. It's remarkable what we can do now in managing this. A lot of these cases can even be performed vaginally by a skilled surgeon. Most of the patients who fail the conservative options will end up with hysterectomy, but it provides them another option rather than having to go through a major abdominal procedure.
Options are good, and we can be thankful for that modern medicine. Thank you, Dr. Bruno, for joining us, sharing your expertise, and keeping us healthy.
You're welcome. Thank you for having me.
If you would like to make an appointment to see Dr. Bruno, you can give his office a call at 716-656-4077. That's 716-656-4077. He has 3 offices he practices out of at 5959 Big Tree Road, Suite 102A in Orchard Park, 520 Delaware Avenue in Buffalo, and 1000 Youngs Road, Suite 106 in Williamsville. You can go online for more information also at gppconline.com. Thanks for watching. Be safe and be well.
A production fee for the preceding presentation of Your Hometown Health Connection was made by Buffalo Healthy Living Magazine and its sponsors.